And actually in the Bible it says, I think it's in Exodus, not Exodus, but Genesis 25. It says that when Isaac got married to Rebekah, he was 40 years old.
Yes, yeah.
And he entreated of the Lord for his wife to be what? To be pregnant, to bear a child.
Yeah.
And it didn't happen. And then towards the end, I think it's verse 26, I could be a little bit wrong, around verse 26, when Rebekah bears the twins, Jacob and Esau, it says that Isaac was 70 years. So Isaac was 60 years old when the twins were born. So 20 years, wanangangana na infertility.
Wow. Could it be, and now that you're talking about it, could it be like sometimes infertility is genetic? Because remember, Sarah, the mother, didn't have. Could it? Because some people have had, like I know ladies.
Yes.
I know some ladies who in their family, ladies, all of them, they've not been able to give birth. So is it genetic? There
is an element of genetics. There can be an element of genetics. Why am I saying this? Because we do know that, for example, for men, you may have what is called congenital absence of the vas deferens, which is a very important sort of pipe where the sperms pass through. So, and that is genetic. So that one we know, because there are cases whereby we've seen and we've read, gentleman is married, anaenda wanaishi, and then after some time the wife gets pregnant, wanazaa wawili. There was a case like that in the UK where the guy had 3 children. And something happened, they divorced. This guy was a businessman, paid a lot of money for divorce and so on. And then he got married to somebody else. And he was about 40 years. He knows he has 3 boys.
So he's thinking
the first one was actually in university.
Yes.
So they try to have this baby and it's not happening. So they go and have a check. The guy does a semen sample and it is 0. And they do another one, it is 0. So what they did a genetic check, and the consultant who saw them told them, you know what, you will not be able to have children. And the guy was like, but I have 3 boys. And he said, well, most probably they may not be yours. So the guy was shocked, goes back to his wife and says, look, we are trying to have babies with my new wife, and I've been told that I'm not able. So how watoto ni wanani? Of course, the first wife dodged. And then, it happens in life. Some things some throwbacks start, sort of coming out of the wood, as it were. And then he remembers the wife. There's a time the guy she had to go to London, sijui mkutano, akaishi, overnight, 2 days, came back, and then soon after that, I'm pregnant, and then now when he actually confronted her, she actually confessed and said, you know what, you remember that time, this is what happened. The other time, this is what happened. Yeah, this is what happened. So 3 boys from somebody else. He reared them up as his children. They know him as his children. When he tried to get in contact with the guy in university, didn't want anything to do with him. The only boy who a very sad story, it was in the Daily News, Daily Mail, sorry. Very sad story. The only person who actually acknowledged and accepted that is his father, and he was not going to change his position, was the last boy, who was, I think at that time was about 15, 16. So yes, there is an element of infertility, but then in the Bible it is so clear. Sema Rebecca was Miriam was 90, alikuwa na mtoto. Sarah, sorry. Sarah was 90. Rebecca, tumeona 20 years. Rachel, Jacob's wife, you remember? I think the guy was out of this world, very a romantic out of this world. 14 years unafanya kazi, una sweat until he gets the price of his life. And then and so on. So there could be an element of genetics involved. Now, when it comes we started talking about infertility. Again, let me take you a little bit back just to give sort of a background.
Yes.
1978. 3 momentous things happened in the world at that time. Mzee Kenyatta passed away. Yes. That was in August 22nd, 1978. The Catholic Church, for the first time after very many years, chose a pope who was not Italian.
Yes.
And that was John Paul II. Now when I'm Catholic.
No, I'm not Catholic, but I did theology.
You did theology.
And it's also history.
Yeah. Now, actually, the guy was from Poland, a place called Krakow. They call it Krakow, but it's actually pronounced Krakow. And I know the place because that's where I actually trained.
Okay.
And then the third most important thing, which actually is the basis of our discussion today, is that the first test tube baby was born in 1978.
Yeah.
First test tube baby, Louise Brown, she was born, I think, in July, I think 15th. And it was a momentous, shock to everybody. And just like in everything in nature and in science, something new, there will always be people who will say, what is this? What is this guy doing?
Some people said it was demonic.
Demonic? Actually, some of the people said, these guys are going to start, creating Frankenstein babies, babies with green hair, or I don't know what, monsters, and so on. And then the most, I think, for me, when I go through this information, something that shocks me is the pushback by the church, where it says, this is not the right thing to do, and we are going into spheres which are not our spheres. We are going to be God,
dangerous territories,
and we are going to create. We are acting God, and so on and so forth, which is not right. Kwa sababu gani? These couples who are struggling with infertility, as I said, it is a stigma, it is a psychological problem, it's a medical problem, it's a cultural problem, all of them put together. Yes. And there is nothing that a woman desires as much as having a baby and being called mama so and so. So the church, in as much, even now, by the way, where I trained, I said I trained in Poland, very Catholic country. A lot of pushback about doing IVF, a lot of pushback about contraception, which you're going to talk about, and other things altogether. Yeah. So just to give, that sort of background, that this is actually, when you look at it in the wider, sort of spectrum of medicine, this infertility medicine, or what we call reproductive endocrinology, is actually a tiny blip because it's only 45 years, around 45, 46, 45 years.
Yes.
And 7 million babies later.
Oh, that is nice.
Because from that time, that's 1978, till now, about 7 million babies have actually been born through this method.
That's a huge number. That's a
population. It's a huge number. Yeah. It's a huge number. Yeah. The Kenyans here is a tiny population, but I think we are slowly catching up relative to other countries in the region. When you look at them, I think we are quite a number of years ahead, but relative to other countries, we are also quite a number of years behind. Lakini tutafika, like one of our sisters said, our dreams are valid.
Yes,
tutafika siku moja. Now, when you talk about IVF, we talked about the causes, we talked about this and that. There is a problem, and how can this problem be solved? The guys who came up with this idea, actually they borrowed it from veterinary medicine.
Okay.
Where they would take sperm and they would fertilize eggs, and then they would transfer the embryo into a cow.
Yeah.
So that is the technology, but they had to understand how a woman's body behaves and how that can be done. In the beginning, it was quite hectic because what they had to do after giving medications, actually they gave what is called clomiphene citrate, where the ovary produced 2 or 3 eggs. Follicles first, and maybe 2 or 3 eggs, and then they had to collect the egg laparoscopically. Took the lady to theater, made a small hole, hapa kwenye kitambi, not kitambi, but kwenye kitovu, and they went in and they punctured what you call the follicle, and that is what carries an egg, and aspirated that fluid, and then they had to look for the egg. Actually,
that was some time back.
That was the first one,
the
very first one, the very first one. So once they saw the egg, the husband of now the father of Louise Brown gave a sample, and what they did, they just put the sperm and the egg in a dish, wakazieka in what is called an incubator, which is around 37.1.2 degrees. So they waited 1 day, 2 days, because Physiologically, once that sperm meets the egg, fertilization occurs, and then what we call a zygote first, because that's a zygote, and then starts dividing. First of all, it divides into 2 cells, and then it goes into 4 cells, and then it goes into 8 cells, and so on. So they took that on day 3. And then they transferred it back into the woman, and then gave her medications, and then they hoped for the best. It was not actually the first trial. They had tried before. There had been 1 or 2 pregnancies which ended up in miscarriages. But this is, after many trials, this is the one which actually succeeded. And hey presto, the lady got pregnant. Everything was uneventful, and she had a cesarean section. The mother of Louise Brown had a cesarean section in a place called Oldham. And that is how now the door opened to IVF, which has helped a lot of people, a lot of women, as I said, 7 million babies later from that time. We are talking about IVF. Watu wengine bado, they still have issues with that, but that is a different story altogether.
That's not the conversation.
That is not the conversation. Now, when do we decide that now this couple needs IVF?
Yes. Who qualifies?
Who qualifies for IVF? Yes. Now, remember, this is a medical procedure. You can't decide today that mimi nataka nikapasuliwe ubongo. You can't, because of the possible complications. Even though, ladies and gentlemen, we go and do plastic surgery here and there must be, sort of qualifications. Even some of them, well, we will not talk about that. Now, this lady or this couple, the lady has, for example, blocked tubes, whereby this sperm or this egg, the eggs and the sperm cannot be able to meet. This gentleman has very few sperms, for example. They are not swimming properly. The number of normal sperms are also not very many. We have issues with the age of the woman. She has been trying for, X number of years, because like I said in the beginning, Rebecca, 20 years. We have ladies.
Another one
90. So we have these couples who've been trying for 5 years, 10 years, and so on. So age is catching up on them. And we can't do anything else. So they qualify. We have ladies who have, for example, issues with fibroids. They have huge fibroids, such that even if we try to remove these fibroids, we may end up basically demolishing the womb completely.
So those ones cannot qualify.
No, they qualify. They qualify. Now, there are also other cases. For example, I have a patient who had heart surgery. Once you've had heart surgery, then IVF, you qualify for IVF, but somebody else will have to carry it for you.
Or like a surrogate.
So we can talk about that later on, because it's also part of IVF. Brain surgery. The women who've had brain surgery, then obviously they can't be able to carry the baby themselves. We do IVF using their own eggs, and then somebody else will carry the baby for them. There are cases whereby, for example, a woman is born without a womb. Then obviously, that baby has to be carried by somebody else, and so on. Now, sometimes we find cases whereby the woman is here and the man is abroad. What we do is say, and they rarely see each other. They see each other maybe once a year for 2 weeks or for 3 weeks, and they have tried, the best they can. Then you suggest, the best thing to fanya IVF, to pate mayai, we create embryos, we freeze them.
That's what you call harvesting.
We call them harvesting. I want to walk us through. Basically, we give a background, then I'll walk you through what the IVF process looks like. Specifically, step by step. So now, once we have looked at this couple, they have come, we have discussed, we said this is a problem, and now the best solution ni kufanya IVF. When do we start this process?
Spice.
We were talking about who qualifies.
Yes.
And you were telling us who also doesn't qualify.
Yes.
Women who've had brain surgery, heart surgery, and others. Continue.
And now the IVF process.
Yes.
Step by step. So once we met that qualification that this couple needs IVF, and I normally walk them through, such that they have an idea what exactly they should look forward to.
And the challenges.
And the challenges as well. So we start the treatment on day 1 or day 2 of the cycle. Once the period starts, that is day 1, normal flow. So day 1 and day 2. Why do we start at that time? Because the body is what is called down-regulated. In that the hormones have gone down, and then now we are starting a fresh cycle. So we want to start with that cycle so that we run with it. So when the lady comes, were two things which we have to do. We have to do a blood test to assess her hormone levels, because I think I mentioned about hormonal imbalance.
Yes,
some of the hormones actually can affect, the process and even the outcome.
Yeah.
So we want to make sure that her hormone levels are fine and that her ovaries are also okay by doing a scan. This can be a bit, uncomfortable for the ladies because they have a flaw, but we have to do a transvaginal scan. So what will I be looking for in the scan? I'll look at the ovaries. The ovaries should not have any structure, for example, a cyst or anything else that can stop this lady from starting. Because if there's something there, it will also affect the hormone levels that we are going to check. So we have ascertained that the ovaries are okay and the hormone levels are fine. So we start now the process. The process basically entails daily injections. And these injections start on that day 1 or day 2, and they will continue for about 10 to 14 days.
So every day they're injected?
Every day kuna injection. Every day. Now, depending on the age, depending on the hormone levels, depending on what we saw on the ovaries, I will adjust the dose of the medications that I'm going to start with accordingly.
Yes.
The younger they are, the lower the dose, because they have more eggs which are waiting to be to be stimulated.
Yes.
The older they are, the slightly higher the dose because they have fewer eggs. So daily injections for anywhere between 10 and 14 days. In the process in between, we will do a scan every so often. It can be every 3 to 4 days. We will do also a blood test to also look at our hormone levels. Why do we do this? Because number one, we want to see how these medications, these daily injections, are actually, whether the ovaries are responding the way they should, and whether those follicles, a follicle is what carries an egg, whether those follicles are growing and they're growing steadily. They usually grow at about a rate of about 1.52 millimeters a day. Now, when it reaches a certain level, remember, again, we are going a little bit into physiology, which we'll talk about in the contraceptives. As the follicles are growing, they release a hormone called estradiol. It's part of the estrogen family.
Okay.
And this estradiol will actually now start working on the womb, on the lining of the womb, what we call the endometrium.
Yes.
And how does it do this? By accumulating a glucose, by making the vessels, become more and a little bit more blood to start flowing there, because now we are preparing for a baby to implant there. Okay. Now, as we are doing these scans, we'll also measure that thickness of that lining, because it's very important. We need a certain measurement by the end of it all. So we continue doing this, and remember, as
this is for 14 days,
for about 10 to 14 days, maximum 14 days. And then remember, the way God has created us, I think I mentioned it again the other day, as those follicles are growing, that estradiol that they're releasing, it will reach a certain threshold, and the brain, there's a part in the brain called the pituitary gland, will trigger and say, because normally it will say, at this level, that follicle that is growing, you need to start ovulating. So it starts releasing a hormone called luteinizing hormone, which is supposed to act on the follicle to make it ovulate and release an egg. So we have to be careful, because if we continue just giving one medication, the brain will start releasing huge amounts of LH, luteinizing hormone, and she may end up having premature ovulation. We don't want that. So what we do, we add on another injection. So this injection is to stop now the brain from filling that high level of estradiol and then releasing that other hormone, so that the lady can ovulate.
The injections are many, though.
And that's what you've just said is crazy, because that's what a contraceptive does. Wow, mind blowing.
Yes. So now we can continue giving this injection, this stimulation injection, comfortably, knowing that as we are giving this injection, we are giving the other injection stop. Yes, so there'll be no ovulation. Tunafanya scan maybe around day 10 or day 11. Remember, we've been doing scans. So if we do around day 10 of stimulation, and then we find that the follicles are the right size. Which size are we looking at? We are looking at around between 18 and 20 millimeters. Sometimes not all of them will get there, but we want as many of them to get there. So when it reaches there now, we give another injection. Remember, we are giving one for her not to ovulate.
Yes.
Now we want
and then the daily ones.
Yes. Now we want to give one last injection, what is called a trigger injection, so that they can quote unquote mature the eggs and make them easy to be released from the follicles.
Okay.
Now, after that trigger injection, 36 hours afterwards, we take this patient to theater. Now for harvesting of eggs or egg collection or pickup, whatever it is.
So it depends whether it is for fertilization or for surrogate.
It doesn't matter.
It doesn't matter.
It doesn't matter.
It just has to be harvested.
We have to harvest those eggs.
Okay.
So we take her to theater. We put her to sleep. The first time I saw egg collection and in medical school in Poland, it was horrible.
Why?
Because there was no medication. The lady was not put to sleep.
No.
It was out of this world.
That's crazy.
It is when I realized that
painful.
it is horribly
That's
painful. It is horrible. It's when I realized that
Jesus.
once a woman has determined in her mind that she wants to have a baby, she will actually
undergo anything.
She will undergo anything. And now they used to give her something very small, some Panadol, some whatever it is, so that they can go in and collect those eggs. Anyway, these days we put them to sleep.
Yeah.
So we give them what is called sedation. They sleep for about 15 minutes, 20 minutes, maybe half an hour if we have a lot of eggs. So we collect the eggs through the vagina. So the first thing when you tell this couple that we are going to theater, they are shocked. We are tunaenda kukata. Hakuna mali tunakata. Okay. We do the egg collection transvaginally. Okay. We use quite a long needle, which is about that long. How many centimeters?
That
about
looks like very many.
Looks like a vet.
And those are they look like very many centimeters.
Yes.
It's about 20 centimeters.
And that woman had that when she was not on like that. It was that long.
Actually, it was that long, and it was horrible. It was hata mimi nilisikia huo uchungu wakati wanatoa hiyo mayai. But she managed and they got the eggs out. Anyway, so once we have got, how do we do this? We do this under ultrasound. So we have somebody here who shows me, because when I go in with what is called a probe through the vagina, and this will show me, actually to show me the follicles, and I know how I'm going to collect these eggs. So once I've done the egg collection, I pass them over in a tube to somebody in the lab, because we must have a lab, a scientific lab, and this scientist is called an embryologist from the embryos that we create. So she's the one, or he is the one who actually creates the embryos. So as we are collecting these eggs, the partner uko naye pia anashughulika. Tunampatia whatever container,
because he also has to harvest.
He also has to give his sample.
Yes.
So he gives his sample. It is brought to the embryologist. First of all, the embryologist will say, Daktari, today we've got X number of eggs. We've got 15 eggs, we've got 20 eggs, sometimes we've got 4 eggs, whatever number. Now, once we have that report that we have so many eggs, actually, basically, my job is now sort of over until the next time when I'm going to do a transfer. Kwa sababu gani?
It goes to the embryologist.
The embryologist now will take the eggs, will remove some tissues which cover the eggs naturally, what is called denudation. And then now she will actually see how many of them are mature, because not all eggs will be mature. We may get 20 eggs, and out of 20 eggs, we get 15 are actually mature, and the other 5 are not mature. The mature ones, we don't use them. So now, after that, she will take the sample, the semen sample, she will clean it, and then choose the best sperm.
For fertilization.
For fertilization.
Okay.
Zile mbaya zinatupwa. So the sprinters that we talked about the last time, those are the ones that we are looking for. Okay. So she will take one.
Marathoners and these ones who can do anything. Backbenchers,
we want those sprinters, those 100 meters, 200 meters. And then she chops off the tail, because here we don't need the tail. Remember, the tail is important for them to swim to get to the egg. Here we have the egg, so we don't need the tail. So she chops off the tail, and then unasikia huko zinalia mkia umekatwa.
Wow. Science is interesting.
Yes.
And then she takes a very tiny pipette, and takes the egg and injects it into, takes the sperm and injects it into the egg. So she does that for those 15 eggs, and then puts them in an incubator.
Spice.
IVF and matters contraceptive, anything in between, and the processes that pertain to this. We have Dr. Kireki, who is giving us an explanation and more so educating us about this process. We reached a place where we are now fertilizing the eggs, the embryo and the sperm. Proceed from there.
So we have created these embryos.
Yes.
The eggs have been fertilized by the sperm, and they have been kept in an incubator.
Yes.
The incubator has constant temperature. Remember, we are trying to imitate what happens in the body naturally.
Yes.
So a lot of science which goes in there, the percentage of oxygen, the percentage of carbon dioxide, they have to
Everything
be
has
all
to be
balanced.
measured.
They have to be measured.
Yeah.
So they stay in that incubator for several days. In the first, after fertilization, what we expect is that the following day they should divide into two cells.
Yes.
And then they throw what is called a polar body, or two polar bodies. It shows that now they are okay. The way they are fertilizing, they are okay, and they are doing what they are supposed to do. Day 2, they're supposed to divide into 4. So they keep on, multiplying like that. So the embryologist will be monitoring how they are developing. And then he or she will tell us, today is day 3 after fertilization. And out of those 15 eggs that we fertilized, we have 12 embryos, for example. Some of them can stop growing in the way. And
in between that time, they're in the incubation
period. The incubator, yes. Okay. So you tell us we have 12 embryos, and there is a grading system that they have. It can be grade A, grade B, grade C, and obviously grade D, but we don't want grade D. Now, once she has told us this information, remember when we collected the eggs, because this is an artificial cycle, because normally, remember that follicle that we talked about?
Yes.
In the normal cycle, once the egg has been released, it collapses into a structure that is called a corpus luteum, or a yellow structure for that matter. So this yellow structure starts releasing progesterone. And this progesterone is the one which is actually, the name itself suggests gestation, meaning supporting a pregnancy. So it starts releasing progesterone. And remember, estradiol had been produced
the body
to prepare the lining.
To cover the lining.
Now these two work in tandem to prepare like it says in the Bible, prepare the way.
Yes.
So it prepares the way for what is coming, for the embryo to do what?
So all this needs to be done at a certain time before you lose out.
At a certain time. It has to be precise. So we collect eggs. Once you've finished collecting eggs, we give her progesterone. She starts using progesterone because naturally she will not be producing, because what we did, we punctured the follicles. And there was no LH being produced, remember. So after 3 days she comes. It can be 3 days, it can be 4 days, or even 5 days after fertilization. So we can do a day 3 transfer, a day 4, or even a blastocyst, which is a day 5 transfer.
And you do only on the special grades of the eggs?
We look at the embryos. On those the
ones that were
best
fertilized.
Grading. Yes, the ones that were fertilized.
So how long before we move forward, how long do embryos, how long are they stored for? What's the longest storage period?
That is before transfer or even after transfer? Because before transfer, we don't want to exceed 5 days. Because if they stay outside beyond 5 days, they start sort of call it maturing, and that is not good for them. Because they either have to be in a womb
to mature in the womb,
in the womb, or we have to freeze them. We can't just let them hang around like that.
So that's the freezing of the
freezing of the eggs, freezing of embryos. We freeze everything
in between that.
Now I understand.
Now you understand.
Yeah. Wow. Thank you.
Remember, we have 12 embryos.
Yes.
So we tell the couple, out of those 15 eggs we fertilized, we have managed to get 12 embryos, and they're all grade A and grade Bs. What would you like us to do? How many would you like us to transfer? Normally, I do a transfer between 1 and maximum 3 embryos, for the simple reason that we want to sort of increase the chances of at least one of them surviving. Sometimes both of them can implant.
Is this why we've had women with IVF get like 6 kids?
Thank you.
Because they took a bigger risk and it worked out.
Waliweka zote 5.
Walisema kesi baadaye.
Like the lady in Morocco, you remember?
Yes, I saw that.
They didn't say anything,
yes,
but it's not rocket science.
Yeah,
waliweka tu zote wakasema potele mbali, let's see what will happen.
I think they were of the opinion that maybe some might die along the way, so they'll save one, but ended up saving.
Exactly.
And is it reckless?
It is actually immoral and unethical to do that.
Are you serious?
Oh yes, it is.
But look at it, Daktari. Yeah. This is our couple who have been struggling to look for a child.
Yes.
And they've reached a point where they don't know if this is going to work. You know, it's a 50-50 chance.
Absolutely.
From what you're saying, is that along the way, an embryo could die.
Absolutely.
So for them to say, let's put in the 6.
Yes.
In case anything, how is it immoral? They're just trying to weigh their options.
There are wrong options to weigh in the first place.
Okay.
Kwa sababu gani? I had a case like that in KNH not too long ago. I saw this lady and then she went elsewhere. Wakawekewa sita.
So who is at fault here? Who should have advised otherwise?
The doctor.
So it's immoral because of the doctor.
Fault, yes. Because the role of a clinician is to give you advice and give you the best scientifically based advice. So if the guy decides to do a transfer of 6 or 9 like the lady in Morocco, that guy, that is unethical. It is wrong. Why am I saying that? I'm saying that because of one or two things. Number one, if we look at the way the womb is created, it's created actually to carry one baby.
Yeah.
One baby you can carry to term 40 weeks, even 41 weeks, 42 weeks without any problem.
Yes.
When you carry 2, there are chances that you'll get to 40 weeks, not very high.
Some people don't even get to 40.
But for most of the time, you may get to around 36, 37 weeks. Unakuta, it cannot sustain the pressure. When we transfer 3 and all of them take, when we get to 34 weeks, we are happy. I have had triplets. And hizo triplets, they keep me awake at night. Kwa maana akapiga simu anasema I'm spotting, my mind starts racing. Because there is no point of you having triplets and you lose them at 21 weeks or at 24 weeks. It's devastating.
Yes, it is.
And then taking into account the number of years this couple have been trying to have a baby. And the process itself. When you put 4, ukifika 30 weeks, you are lucky. Unaona kama the Moroccan one, it was 9. I think they got the babies out at 20 something.
They had to,
because why? The baby, as the babies are growing, remember it's not the babies only who are growing. You have placenta there, you have fluid there, and you have the fat that you accumulate naturally in pregnancy, and so on. So exponentially you gain weight in a horrible way. That has a lot of pressure. It puts a lot of pressure in your circulatory system. You can't breathe properly. You can't walk properly. You can't sleep. etc. So, like for example, in Europe, and they're doing that, I think, in America. But let's talk about Europe. In some countries, it's only 1.
Yeah, I've heard
it's
about
only 1.
Because I'm trying to imagine if one child gives you that.
Gives you that.
Now imagine 4, 6, 9.
Hata wawili ama watatu.
That's crazy.
It's crazy. So in some countries it is a legal requirement. Ukifanya transfer, it is 1.
Do we have any laws in Kenya for that?
An interesting thing.
Because now when we're talking about immoral,
an interesting thing. When I came back from the UK, I had the chance of sitting with some brilliant guys in this country, in this area. Professor Kireki Omanwa, Dr. Wanyoike, Dr. Dadiala, P.S. Patel, and many others. And they had started, putting a framework together, a bill, which was very supported by one of the members, Millie. We went very far. We actually did a lot of work because there are a lot of gaps in this whole process in this country. But unfortunately, the bill has never seen the light of day. So we are working in not a very good state. So that is why I think now that I said it is immoral and it's unethical, because here we don't have a bill which actually regulates what.
So
what
anyone is doing anything they feel like.
And by the way, you get a good lawyer, there is nothing you can do.
So you just have to pray for a good guy now.
Yeah, thank you. And pray
we'll
God.
Be honest with you.
We'll be honest. And I think it's incumbent on us to actually be very frank and very pragmatic when we deal with this, because it's a very sensitive sphere. This is what we need to do. In the UK, you can only do 1, maximum 2. You can do 3, but on a case by case, sort of process. Because sometimes you find a couple who've been trying to have a baby for 10 years, 5 years. So when you put 1 or 2, the chances of implantation are slightly lower. So we want to increase that by doing a transfer of 3.
Okay.
So once we have gone through these messages with the couple, wamekubali kwamba we can transfer 3, we book this lady. She comes in. She needs to drink at least half a liter of water. Why? Because the bladder has to be full. The transfer is done again under ultrasound.
Yes.
So we need what we call an acoustic window so that we can see where the womb is and the lining, that endometrium that we talked about.
Yes.
Once we've identified that the conditions are ideal for transfer, the embryologist will give me the embryos in a pipe, which I will maneuver through the cervix, which is the opening of the womb, and go and actually I can see where I'm going. And most of the time we want to put it midway, right in the middle of the endometrium. And
not inside.
It is inside. It's inside the womb. It's inside the
so
womb.
It can't backfire.
It can't backfire in the sense that it can't come out.
Yes,
that is number 1. But number 2, sometimes it can go in and then go into the tubes. Sometimes it does happen, such that you end up getting an ectopic pregnancy.
Oh, yeah.
Sometimes you can get an ectopic pregnancy and a normal intrauterine pregnancy.
So how do you balance that? Do we remove one and save the other one?
We remove the ectopic.
And still it will not affect the other one?
It shouldn't affect the other one.
Now, in terms of surrogate, because we talked about issues of surrogate, I know that is the same process.
Yes.
But the question I've been having is, for example, let me give an example. Maybe I and Karigo are here and Karigo has agreed to carry for me my babies.
That's right.
But the question is, because I've had some people say there's usually a gap window that in the event Karigo decides to have intercourse, that she can end my child with my eggs and my spouse. They can end up having her genes. Is that true?
No, it's not true.
Okay.
It's not true.
And can she kill my eggs and hers survive?
No.
With a pregnancy?
Remember, when a woman gets pregnant, the hormones, again, we come back to the hormones.
So mine will survive regardless?
They will survive. Okay. They will survive because immediately that transfer has been done, and we give her medication. We normally give medications for 2 weeks. Actually, they have a small pharmacy at home. And after 2 weeks, they come, we do a blood test. We are checking a hormone called beta HCG, which is actually released by the embryo, which the baby now who has implanted. Very interesting because that beta HCG is almost similar to LH. Remember we talked about that LH?
Yes.
So it will work to stop the other processes, the natural process from beginning, and it will help the progesterone as well.
Oh,
okay.
Beautiful.
So it balances out.
I mean, it is just out of wale wanasema tulitoka kwa nyani ni hao tu walitoka. Sisi hatukutoka huko.
Wow, science is amazing. Okay.
So after that, we once we've confirmed that.
So now you've put inside in the middle.
Yes, we've transferred.
Yes, we've
transferred. We transferred. We ask her to go home.
Yes.
Obviously, we don't want her to lift heavy things.
What's this thing that they say go up and put your legs?
No, it doesn't make sense.
It doesn't.
Those are just myths.
Okay.
I mean, it's just the same thing when you're having when you're trying to get pregnant naturally.
They tell you to put your legs up.
Ati wekelea miguu juu. Kina nani wanafanya?
Daktari wengine wanaambiaga watu hivyo daktari. You know, there's a doctor who told me that.
Oh, really?
Yes.
Uliekelea juu kwenye?
Wacha tulisema ukweli.
No, but it's true. Even when I've had stories of like my boys telling me, nalieka miguu juu akina mshuku. I'm like, what are you talking about?
No. Because listen, why do I say it doesn't make sense?
Some of these doctors have been lying to us. Don't forgive them.
Why do I say it doesn't make sense? Simply because once an ejaculation has occurred, and those sperms are swimming into the cavity.
That's it.
Wekele miguu juu, usiekele juu sitaenda. There's no return. Zinaenda. And we want them to go with their
own speed.
with no return to sender.
Spice.
Who qualifies for contraceptives, and what are the factors to consider if you're a man or a woman?
Now,
and I'm saying a man because some of them are married. And let's have this conversation. Let's not leave it to one gender.
No.
And let's be as raw as possible.
As raw as possible. Yeah. Okay. Now, first of all, when we talk about contraceptive, as the word itself, suggests, it's against getting pregnant. Contra. contraception.
Yes.
And we get it there. If you talk about hormonal contraception, the idea came around the 1900s, but they did not come to fruition until around 1960-61, when all of a sudden they thought, wow, we've used this. They actually used to get the hormones from animals. But with the time that
which
has been refined, yes, hormones are the same.
Which specifically? Which animal?
A cow.
A cow, for example.
And a dog.
By the way, even now, we're talking about IVF. The medications that we use, some of the medications, we get them from urine of menopausal women.
Yes.
And then they are purified. Hatutaenda hapo nano umeniangalia vibaya.
Amestuka.
So when it comes to contraception, first of all, there are different groups of contraception. You can broadly divide them into male and female. Let's start with that.
Yes.
And then in the female ones, there are also different groups. You can say the natural, for example, short-acting reversible, long-acting reversible, and then the permanent ones. So when we start with the natural ones, actually, you can't even call them contraception. Kwa sababu gani? Which ones are they, first of all? There is what we call the rhythm method, where basically a woman measures her temperature every day for 3 to 6 months. And it has to be at the same time, in the morning, from the same place. It was suggested that it has to be measured vaginally. Now, if you do
Does that really work?
Yeah,
that's what I want to say. That's what I want to say. Now, you plot it every day, and when it comes to around ovulation time, the temperature will rise a little bit, and that will be an indication of ovulation. So when you do that for 3 to 6 months, you will actually see a pattern, and you'll see when this temperature rises. So when that temperature rises, please avoid this man. Like the devil, if you don't want to get pregnant. So because ovulation has occurred.
Yes.
But if you want to have a baby, then this is the time you need to do that.
When the temperature changes.
When the temperature changes.
I'm
Slightly
sure
by about 20.
someone's going to try this.
Like it has to be done for 3 to 6 months.
Okay.
Religiously kila siku. Not a good method. Kwa sababu gani? If you have a cold, for example, you have an infection somewhere, whatever it is, something that will affect the normal physiology of the body, you will not, the temperature will come at the wrong time, and then this method doesn't work very well.
Or even the change of temperatures, can that affect?
Or even
like the way the weather is fluctuating.
That one doesn't affect much, because there is a center in the brain which actually maintains the temperature of the body at a certain range. It can't go beyond unless there is a disease. You know. Now, that is not a method, but it is a method which is propagated in some circles.
Yes.
There is what we call the Billings method, and the Billings method basically is you check the vaginal discharge. Again, you have to monitor it, and then usually when you are around ovulation time, the vaginal discharge will change. It will become watery, it becomes slippery, and kama makamasi.
Yeah.
Again, that is physiological, because if there is intercourse at around that time, actually that discharge is supposed to help the sperms to swim to get to where they're supposed to swim. Nothing is inafanyika tu as an accident. Everything has a purpose. Has a purpose. Now, after that has happened, or even before that, usually after ovulation, the mucus changes. It becomes thick and whitish. Again, there is a reason for that, because you remember that progesterone we talked about?
Yes.
It causes now the mucus in the vagina to change, to become thick. Sperm cannot penetrate through. Sawa. Now,
okay. Now it makes sense. Yes.
Now, the problem with this again is that sometimes some women will see that mucus and others will not.
Yes.
If you have irregular periods, that mucus may not be there, or it will come at a completely late date. For example, we talk about polycystic ovarian syndrome. The periods are all over the place. You may not have that mucus. Kwa hivyo hawa wakitaka kupata mimba itakuwa ni kubahatisha.
Yes. Because of the irregular cycle.
Because of the irregular cycle. Now, kuna ingine, the one they called where you have the man has to withdraw. When you're having intercourse, when the man is almost ejaculating, and he has to withdraw. Somebody said hiyo ni kama unataka kusimama kwa basi, but you get there, basi imeondoka zamani. It's not there. Now, what happens is, why this is also not a method, because even just before the ejaculate comes, the pre-ejaculation fluid can or will have some sperm. So you'll find some methods say, sisi tulikuwa tunatumia ile coitus, it's called coitus interruptus, but we got pregnant. Now, there is a way that we actually sort of see which method or which of these methods is effective, and that one is we look at X number of women who have used this method of a certain period of time and how many of them actually got pregnant. These three methods have a 90-something% failure rate. So ile ya kutoa, ile ya kuangalia billings, the vaginal discharge, and that one of measuring temperature, they are completely unreliable.
What about the one for counting?
It's the same.
It's still the same.
It's still the same, especially when you have irregular periods. It will not help. Sawa. Now, we go to the next group, which is hormonal. Again, very wide, because there are different types of hormones. We start with the most common one, which is contraceptive pills. Now, even in the contraceptive pills, there are also two large groups. There are what we call combined oral contraceptive pills, and then there is what we call single hormone, contraceptive pills. There's a difference. Now, in the combined oral contraceptive pills, the pills have two hormones. Remember we talked about that estrogen, and then there is progesterone. So when a woman takes these pills, what they do, they actually interrupt the normal process. So the ovaries, if you can equate an ovary to a factory, which is producing eggs all the time. So when a woman takes pills, what happens is that this factory goes into inafungwa kiasi. But it doesn't mean it's completely closed, because there'll be small amounts of estrogen which are being produced.
Just like it's been put on pause.
It's been put on hold. They produce small quantities of estrogen, which are important for the normal functioning of the female body. So the combined oral contraceptive pills. Then there is the single hormone, which is just basically for progesterone. Now, there is a reason why we have these two large groups of pills. The second one, let's start with the second one. This one is usually for women who have delivered. Because whatever tablets they use, they can actually be excreted in the milk, and if the baby is suckling, can actually take those especially estrogen. No baby wants estrogen. We don't want babies to take estrogen. But with the progesterone, it's okay. And actually, this one is indicated in women who have delivered and don't want anything inserted in the uterus.
That's what you call just single pill.
Single pill.
The other one is combined.
Or a mini pill. We call it a mini pill.
Okay.
The other one is combined. Now, who qualifies? Because that was the question. Who qualifies for this? Let's start with the pills. There are some contraindications, which are these ones we can't give. For example, if a woman has had what is called DVT, that is, you have clots in your veins, that one you cannot give contraception. The combined pill. The progesterone, the mini pill, that one is not really contraindicated, but you have to be very careful. Personally, I wouldn't give.
So in short, it will be better for them not to take.
It will be better not to take. If you've had surgery, for example, you had brain surgery, we can't give you. If you have high blood pressure, we can't give you. If you have diabetes, you can't use the oral combined contraceptive pills. If you are a smoker, that is also another thing. If you've had issues with your chest, for example, if you have, for example, you had trauma, in a short while, if you are immobilized, for example.
What about asthma?
Asthma we can give. And so on. If you're overweight as well, if your BMI is more than 30, that is also a contraindication for using combined oral contraceptive pills. Why is it a contraindication in these instances? Because remember, those hormones that we are using, that we are giving, can actually increase the the viscosity, the blood becomes a little bit thicker, and then the chances of clots happening is a lot higher. So we don't want to give these patients in this category these medications. Whom do we give this contraception to? Patients who want to space their families. For example, you've delivered, you don't want to have a baby in the next 1 year, 2 years, 3 years, so you can actually space your family with this contraception. Patients who have, for example, who have heavy periods. If you have very heavy periods, we can give you contraception pills, and the periods will actually be lighter. Patients who have endometriosis, I think I mentioned that in one of the courses of infertility.
You did last week.
That one. If you have painful periods, and this is a big problem amongst women.
Yes.
If you have painful periods, we can actually give these contraceptive pills in these patients. If you want to push away your period, for example, you're getting married, and then when you do your calculations, you find your honeymoon is going to fall on the day. Your periods are going to fall on the day you're having your honeymoon, and your honeymoon, you want to really have honey. So you can use these pills to actually push that period away.
But now I have a question on that, because I've had women ask that, and some of them have said it's backfired.
Yes.
Because they don't use the pills that you're talking about, the 28, 30-day pills. But in the market, we have, I think, is it 4 pills, or there are other pills?
Yes.
Are those the same ones that you're talking about, or these ones are different?
Now, we are talking about the 21 or 28 day pills.
So those are the ones you're saying that being used to push.
Used to push.
Not these other ones that people buy 4, I don't know, 2, then you pop, it will disappear.
First of all, it is wrong to use them that way, because those are emergency pills, which are supposed to be used in an emergency situation. But from where I see it, and from what I hear patients tell me, it is what is happening with our young people, or with ladies in general, younger ladies. It's just out of this world. You go wherever you go to visit.
They are going for WCR, Naivasha over the weekend. So they've popped a pill today.
They have carried them in their backpacks.
So it's just an emergency pill that someone has taken to shift their period.
No, that is not for shifting. That one is basically to stop any implantation from happening. But you see, what they do is they use this today, tomorrow wakikutana na mwingine anatumia ingine. You can't have an emergency every week.
So it actually delays their period along the way.
It can
delay. But Daktari, my question is, and this is something that really bothers me.
Go ahead.
So if it delays the period, once the period finally comes, haitakuja na so much oomph and pain and
not necessarily
heaviness and clogginess and all those nasty things.
No,
that really Karigo.
I
hate periods.
Actually, there are different ways of using periods.
Yes.
You can do it cyclically, meaning you start from day 1, use it for 21 days. There are some which are 21 tablets, others are 28 tablets. The ones which are 28 tablets, the 7 are dummy tablets, which are usually, what we call the iron tablets. Iron tablets.
They're supposed to be taken.
You can take them. It doesn't matter. They are dummy because umezoea kumeza tembe kila siku. Sawa. So when you finish the hormonal ones, which are 21, it's a reflex action. So if you don't having it, you feel as if something is not right. So you want to keep on swallowing so that they are 28. But actually the active ones are 21. So you find in one pack, there are some which are 21, others are 28. Now, when they start taking, they can take 21 days, and then there's a break of 7 days where there is a period. Then they start again. So that is cyclically every month. But you can actually use it even for 2 months or 3 months without a break. For example, if you have heavy painful periods, you can actually use it from 1 to 84 days. 84 days, about 84 days.
You just take, after 21, you start another.
Ikimaliza unaendelea.
So it will stop your period.
So it will stop your periods for those 3 to 4 months, and then when you stop, you have that period once.
Spice.
Before we went on the break, Dr. Kireki was sharing about the types of contraceptives, and we finished about pills. What about the hormonal ones? What other hormonal contraceptives are there in the market?
Yes, we have injectables.
Yes.
And these injectables, you can do, a lady can have it done once every month. In some places, they have it once every 3 months. And very comfortable. You don't have to remember anything. For the tablets, you have to remember every day at a certain time you have to take it. You can't miss, or if you do miss, then you may have a chance. There's a possibility that you can actually get pregnant. So it is advised that in the pills, if you miss one, then if you're going to have intercourse in the next 7 days, you have extra protection. But with the injectables, once you've been injected, that's it.
So every month you have to inject yourself?
Every month.
You have to go for an injection?
You have to go for an injection. But now there's something which is coming into them. It is hormonal.
Okay.
It's hormonal. There's something which is coming into the market. There was some study which was done to see how patients can actually self-inject. They don't have to go to the doctor. There is also what you call an implant, which is also put under the arm or on the arm for that matter, and this releases a small amount of hormones every day into the system. There is what we call a ring, a Nuva ring. The Nuva ring, you insert it inside the vagina, and it goes and stays on the cervix, and then it also releases a small amount of hormones every day, but this goes right away into the uterus. So externally, that is in the other organs, we actually don't get a lot of those hormones getting there. Very comfortable and a very convenient way of doing it. You now insert for 3 weeks. After 3 weeks, you remove it, you get a period, you start again. And then there are patches as well. Yeah. And these patches are also very convenient. They are not very available, but in some places you'll get them in this country. The same, you put one patch every 7 days. The only place we want to avoid putting these patches on the breasts, but you can put it on the shoulder, on the back, on the abdomen.
You wear like for a whole day?
For a week, for 7 days.
You don't shower, or you remove and put, or you put another one.
You shower.
But you just leave the patch there.
You just leave the patch there.
People are doing things out
here.
yeah, but I know many people who prefer that a lot.
Yes,
more often than not.
Actually,
why is that?
Younger ladies prefer that.
Because of university. Why
ladies.
Is that?
Maybe they don't want to use or alter themselves.
Maybe, but I think the issue is the convenience.
Yeah,
you just stick it on
and you go
7 days. Unajua tu, I put it on Monday, I'm going to put another one on Monday after 7 days. So very, very convenient. Once we finished with that, those are still hormonal.
Yes.
There is now there is a hormonal where we have to insert a coil. There is a coil. There are two types of coils. There is one which doesn't have any hormones. The other one does have hormones. Now, the ones we're talking about coils generally, with the coils we insert them again during the periods. Kwa sababu gani? Because once a lady is having her periods, the cervix, which is the entrance into the womb, is slightly open, and it is more comfortable that way. Unlike inserting it when you're not having a period, it's going to be quite a big challenge. Now, this coil goes and settles inside the endometrium and stays there. And basically, because it is there, the immune system will start producing some chemicals. And this should stop any implantation from happening. That is one. Number two, the fact that it is there. You remember, the embryo is microscopic.
Yes.
So if there is something which is there, like a coil, it is something huge for it. So for it to circumvent this coil becomes a problem. So it will not actually, it reduces the chances of implantation. However, there have been cases whereby women have coils and they still have got pregnant, especially the copper coil one.
Yeah.
Especially if it is displaced a little bit, then it may not be actually be functioning, doing its function. So those are coils.
Yes.
Now, the coil which has a hormone is impregnated with hormone. It's also inserted in the same way. The beauty with this is that once it settles in, it works in two ways. It works mechanically,
yes,
and then it works by releasing a hormone, a progesterone. And what that progesterone does, it makes that lining of the womb to be thin.
Yes.
So especially in patients who have very heavy periods, this is one of the things we actually propose. We said, you can try. If you can't take tablets, you can't take this. Why don't you try, using this coil. This coil.
The hormonal or
the hormonal one.
Oh, okay.
The hormonal one. Now, the only thing is that once we have inserted it, this is a foreign body.
Yeah.
So the uterus may start contracting, trying to get rid of it.
Okay.
So we need to give the patient some painkillers for a few days until the uterus has settled, it has accepted this foreign body, and then life continues normally. We have to be careful about the string because we have to leave a certain length of string, hanging outside the cervix, such that later on, if we want to remove it, we can easily remove it. Sometimes the strings can be, they can sort of be uncomfortable for the partner when they're having intercourse.
Do those strings disappear?
Sometimes they can, especially if you cut it a little bit shorter. Remember, for example, when you're having intercourse, there's an orgasm. There are contractions. That one can actually sort of pull whatever inside the womb. Sometimes it can be displaced for whatever reason. So that can be a challenge in itself. Now, then we go to what is called permanent. We are still talking about women.
Yes.
The permanent ones are not many. And before we even go there, we really have to discuss with this patient. And most of the time we do this permanent contraception by clipping or cutting the tubes, usually done during a cesarean section, but they can be done under other different circumstances. You can do it laparoscopically, for example.
How long does it take if you do it laparoscopically?
Yes. It depends on who you get. Somebody who has experience, that is a 5-minute job.
Oh.
Yeah, just to go in,
na
get
kama
the tube.
experience.
Kama experience kwanza hatutaki ya kukaribia.
Those quacks.
because
Don't you look like you have experience?
These are not going anywhere else but his.
because there are a lot of issues that can come up with it.
Yes.
Because remember, this is surgery we are doing. It may be, some people think it's minor surgery, but remember, we are going in, we are inflating the abdomen with gas, and we can injure the guts, we can injure the bladder, there can be bleeding, there can be infection, and so on. But once we have qualified you and we think that you are okay, then there should be no problem. Which patients don't we think that they can have this? For example, if you're overweight, it's going to be a huge problem to get into the abdomen. Okay. Sometimes you may need special equipment to go through all that fat in order to get there. And then remember that while you're lying there, other things can also happen. Okay. So it is something which we don't do very often, but it is an option which
you said it's permanent. So even if you clip, you cannot reverse it.
Now, once we have clipped, remember we clip it, and
because we have not cut it.
We are not cut it.
Yeah, cutting is the permanent one.
Yes. Once we have put, because there's something we call a clip, a fleshy clip we put there. When we put it there that way, remember we are sort of crushing the tube. The body, the immune system will throw some soldiers there, and then what will happen is that there'll be fibrous tissue there.
Yes.
And afterwards, there is no way it is going to be open.
Okay.
Even though some very rare cases that you may have an ectopic pregnancy, but that is extremely rare.
Is it the same case when it comes to men? Is it the same clipping that's for vasectomy?
Vasectomy, now that is that. Thank you for asking about that. Now, for vasectomy, you actually nip and cut.
Okay.
Yeah, you actually nip and cut.
We don't clip.
We don't clip.
Okay.
We just nip and cut, such that there is no connection between a tube which has been cut. There is a gap in between. Now, later on, as I was saying, this is something which we don't do very willingly. Not in the sense that we don't want to do it, but because we talk to the patient and counsel them and say, look, you may have 4 children or 5 children and you want these tubes, cut or clipped or whatever it is. Later on, if something happens and you want to have another baby, it's going to be a challenge. But some of them are very adamant at that time. Sitaki hizi tube nimetosheka. And then later on you find, Daktari, I had what you call a ligation, bilateral tubal ligation done, and now I'm in a different relationship and I want to have a baby. What do we do? Can we open the tubes and join them again? Haiwezekani. But no, you can do IVF, because in IVF you actually don't need the tubes. Yeah. So that one we can do that.
And when it comes to for men,
yes,
there's been a notion or something that's been propagated in the last 1 year that there's the male contraceptive pill. Yeah. What are your thoughts about that? And is it available in our country?
Okay.
Because they said after a year.
After a year. Now, the male contraceptive, remember, there is also a female contraceptive, which is a condom.
Yes.
So there too a diaphragm for the ladies.
Yeah.
Horribly uncomfortable and whatever. At least that's the information you get from the patients. For the men, obviously, we have the CD, which is quite available. And actually, we suggest that men use this, especially as a guard against sexually transmitted infections. And we know there are many HIV, herpes, and so on and so forth.
Yes.
Now, when it comes now to the male contraceptive sensus strictor, as it were, there were some trials which were being done in some countries, and I think Kenyatta was one of the centers which was, trialing this. A big challenge in coming up with a male condom. A male contraceptive is a pill or whatever it is. Kwa sababu gani? The physiology is different.
Okay.
You remember ladies produce one egg every month.
Yeah.
Sawa. Males, every 2.5 to 3 months, they have a fresh batch of millions, if everything is okay, millions of sperm. How do you stop this? So most
you
of
can give them monthly
or weekly.
Or weekly is
every 2 weeks.
Very, very possible, because what we may need to do, we may need to interrupt that communication between the pituitary gland and the testicles. So by increasing, the male hormone, for example, there is what you call a negative feedback mechanism, which will go, say this threshold is too much, so stop releasing, the male hormones. So they block, and in that process, there is no production. But then again, you may stop for that month. But you see, in the previous month, sperm zilikuwa zimetengenezwa.
Okay.
So that is the challenge when it comes to male contraception.
So we can just say when it comes to male contraceptive, it is still under investigation.
Work in progress.
We are not getting there anytime soon. So the bigger burden has been left to the ladies.
Sasa tutafanya namna gani?
Unless they decide to take the vasectomy, which we will not mind.
By the way, uptake is about 1%, which is very low, and especially in this part of the world, tunafikiria kwamba nikisha once I get that nip, that's about it. I mean, you'll enjoy your sex life normally. If it's an orgasm, you'll have an orgasm. The only thing is that there'll be no sperm.
Now let's answer this question for this gentleman, because he's still calling about it. And I can see what he's asking about matters of poor ejaculation. Do you think it's affected by any contraceptive that a lady would use, or it's just a personal thing that someone is going through?
No, poor ejaculation on the male side of things will not be affected by contraception, any contraception that the woman is using, because again, as I said, the physiology is completely different, and these are two completely different entities. So if there is poor ejaculation, then there is a problem somewhere. There could be a problem with the production of the sperm, or even the transport of the sperm. The numbers could be low, motility could be low, which could actually be caused by different things. Could be pengine anavuta sigara, and so on. It was lifestyle, work.
So he needs to check his lifestyle.
He needs to check. He needs to talk to a doctor.
Okay, fast.
Yes, he needs to talk to a doctor. Waongee. Then the doctor will try and find out, why do we have this poor ejaculation.
We have a lot of women who complain of different side effects when it comes to contraceptives.
Yes.
Could it be because they have not properly use the contraceptives is for them or for their bodies, or is it something that cuts across, that if you use this is the side effect? I've had women say, I gained weight, tenderness of their breasts.
Absolutely.
I've had this overbleeding.
Yes.
So is it specific, or is it dependent on what you have used?
Now, by and large, when if a woman is going to use combined oral contraceptive pills, there can be, because this is just medication, these are hormones that we are using, there will be some side effects. Some women will not feel anything, will not have any side effects. Some will actually have a lot of these side effects. What are we looking at? Number one, in the first 2-3 months of using combined oral contraceptive pills, there may be nausea. That is one of the things that they really complain about. Lower abdominal, pain. Breast tenderness.
We've had some people say even low sex drive.
that libido, especially with the injectables. With the injectables, the libido hits the floor. Hawataki kuona huyu mzee, hawana hamu kabisa.
Why is
so
that?
On. Again, it's the physiology of the function of that progesterone that they get. Remember, there's very little estrogen which is being released, and there is no follicle which is being released, and that estrogen is actually what helps you feel now that I really want this gentleman. You become more flatty. Actually, you are more happier. You want this kind of
the feel good feeling.
That good feeling.
Feel good
hormone.
rather.
That one is not there. Feel good hormone is oxytocin. But now that estrogen and that release, that ovulation actually helps you mentally and physiologically to have sex at that time. Again, because it is the way women have been created, because then it increases your chances of getting pregnant. So if this is not happening, then libido pia inateremka. The other thing that talking about side effects, you talked about weight gain.
Yes.
The weight gain that women complain about is basically because of fluid retention.
Okay.
But nowadays there are hormones, there are combined oral contraceptive pills where the estrogen is slightly different, which actually works in the what you call them, in the renals, not in the renals, but in the kidneys, and there's a particular place in the kidneys where it helps fluid, to go out because it doesn't retain
it's
sodium.
like regulated.
It doesn't retain sodium.
Yes.
Sodium ions, so it helps water to come out.
Okay.
So those ones are the newer ones.
Okay.
Lakini zile za zamani, and again the doses of those hormones was also quite different. Even in the tablets that we use, there are also different levels or different doses of the hormones that are there. That is why, as you said, there are some women who take, some have bleeding,
some
have
don't,
this,
some are okay.
Some are okay. So your doctor will have to listen to you very carefully, and then he can suggest, if you started with this, which is a low dose, then most probably this is not for you. We'll give you one which has a slightly higher dose so that it can sort of mimic the normal physiological cycle. Now, the things that we are going to look at and which women should be very aware of when they're taking combined oral contraceptive pills is that, for example, if you have pain in your cuffs, be careful. If you start having issues with breathing, chest pain, stop. Headache, if it's never been there and it started during once you started using the COCs, stop it. If you're having migraines, for example, you have issues with your vision and so on, stop. Because then it is an indication that something is actually not right and you need to stop, and then you look for an alternative contraception.
Is it true that sometimes contraceptives interfere with the reproductive system?
A reproductive cycle?
Yeah, the reproductive cycle, sorry.
Of course, actually that is what it is meant to do.
And
it is meant to stop. Because
Okay.
when you're using the contraception, chances of we're talking about oral combined oral contraceptive pills, or even hormonal ones, because they interrupt that normal physiological cycle. So the chances of you getting pregnant are low. So it does interrupt. Now, the interesting thing is that when a woman stops taking these pills, in about a month to 3 months time, the periods should come back normally.
Yeah.
But if you take it for 5 years, 10 years, sometimes 15 years, and then you stop and you want to have a baby, now, because your body has got so used to, your ovary is not working, it will take a little bit longer for the normal physiological cycle to kick in so that you can start thinking about having a baby.
Wow.
Spice.